Good morning, judges. My name is Elizabeth Delozier, and with me today are my three teammates. Luke Rogers will be giving a cost analysis of the Department of Orthopedic Surgery and the Department of Oral and Plastic Surgery, as well as giving the pros and cons of the TD-ABC model and the RCC-RVU model. Whitney Greer will be giving a presentation over the bundled payment system, as well as the implementation of a new strategic plan through TD-ABC. And Jean Carter will be discussing the value-based care, patient perspective, as well as the measurement of health outcomes. And I will be talking about physician bonus payments. As a group, we believe that the three things that the healthcare industry needs is to formalize a standard measurement system for outcomes and costs, implement a bundled pricing system encompassing the full care cycle, and organize health services focused on the patient and the patient's medical condition. As Porter would say, and I quote, "The remedy of the cost crisis does not require medical science breakthroughs or new government regulation. It simply requires a new way to accurately measure costs and compare them with outcomes." And we believe as a group that what we took from this quote was that the patient and the patient's condition, not the services, procedures, or departments, is the fundamental unit of analysis of measuring costs and outcomes. And this was the lens that we used to view this case study. So our goal was to align outcomes and costs and make sure they're appropriately aligned per patient. So now I will pass the floor to Luke, and he will discuss the cost analysis of the two departments.
Thanks, Elizabeth. In the next two models, I'm going to examine activity-based costing and compare it to the RCC methodology. We first begin with the Department of Plastic and Oral Surgery. We first take the annual cost per professional and we divide that by the clinical minutes available. That gives us the capacity cost rate. In other words, the cost per minute. Multiply the capacity cost rate by the personnel process times in minutes, giving us the cost per patient visit. Now, with this model, we're only focusing on the initial patient visit. After we determine the cost per patient visit, we add up the cost for each professional, and that gives us the TD-ABC. Now, one of the negatives of this model is that one of the reasons why with the RCC cost, which is the total cost divided by total annual charges, that rate by the cost per procedure, that only gives you an average cost. Right away, with the TD-ABC analysis, now understand our true labor costs. Likewise, examining the profits here, every single time a patient further analysis is going to have to be done. Now, the next model actually expands upon the previous model by examining the indirect costs and materials and supplies. For orthopedic surgery, we follow the same steps as before: capacity cost rate, getting the cost per patient visit, adding up the cost per patient visit to get the. Then, unlike before, we add the labor cost to materials and supplies, indirect costs, and now we truly understand the TD-ABC cost per procedure. Now, the RCC total cost, go back up. The RCC total cost, there's a discrepancy between these costs here. RCC is just an average. I want to focus on specifically two treatments here. Long leg cast is a cast that goes on each leg and is connected with a bar in the middle. Compare that to the long leg cast, which is just one cast, and you realize at the end here, the two casts actually cost less than the one. Intuitively, that doesn't make sense. The materials and supplies are less for the procedure that has two casts compared to the one. So we're going to need further analysis on that to understand why there may be inefficiencies and why the costs are different. Likewise, when we compare the profits, we're losing $100 for the full care cycle of treating the patient. So now that we understand the total costs, we have recommendations on how to improve this. First, we need to replace the existing costing methodology and implement the TDABC cost analysis to understand the true cost per patient visit. In doing this, we will be able to reduce the cost distortions that exist. What we need to do is adjust the charges down. Our main competitor has charges that are 50% less than ours. Third, we need to identify the operational inefficiencies. Specifically, we want to focus on the physicians and the cost driver of time. Looking at time, we want to increase the utilization of each physician while they are working on the patients. They're paid under a salary payment, meaning we want them to be working all the time, treating patients, and not doing other things. Fourth, we need to perform a marginal analysis so that we can understand the true variations in the patient care cycle. So now that we have these recommendations, Whitney is going to tell us how we're going to truly implement and make these changes.
Thanks, Luke. So I will now describe how the utilization of time-driven activity-based model can help aid your department in moving towards a more value-based healthcare. Our team agrees with Dr. Muir. No matter how innovative the payment model is that you want to implement, its success depends on the accurate cost so you can value your services appropriately. Listed on the screen are the key components that need to be addressed in order to sort of help remedy our cost issue crisis. By strengthening your information technology platform, specifically our data collection systems, and integrating them into the full care cycle, we can now break down time and report back on the patient's activities and how it's related through their whole experience over the full care cycle. This provides a better feedback mechanism. One tool that we would like to advocate for a data collection system is the radio frequency identification wristband. This tool tracks and reports on medical administration, patient administration, medical equipment, as well as inventory usage and the length of stay. But regardless of the tool that you do decide to implement to strengthen your IT platform, it's important to note that the stronger your data is, the more that your quality of care will be enhanced, as well as it'll be recognized through your bundled payment system and your physician bonus payments. Implementing a bundled pricing system. Here we notice that implementing a bundled pricing system will create potential cost savings, as well as increase the quality of care and increase physician satisfaction. The methodology used to define a bundled pricing system is to define the episodes of care as well as their duration, define the payment provisions such as your risk adjusters and your outliers, risk adjusters being the patient's condition, the case mix, and outliers such as you have high drug costs in one of your procedures or it's a highly specialized surgery. And then using physician input as well as data analytics, you can determine a care path, a standardized care path variation, and then see from there what your bundled contribution margin is. When setting the price, we want to make sure that our fixed payment covers the services rendered and the cost, the accurate cost of those services, as well as the consideration of our reimbursement rate compared to our cost. Once again, cost is our main driver here. Once implementing the bundled pricing system, we want to continuously monitor the outcomes related to cost and provide an internal benchmarking mechanism where we can share best practices and physicians have more transparency to the care path variation and how they can improve to participate in cost sharing and bonus sharing arrangements. And most importantly, we'd like to have everyone involved in the healthcare buy into this whole process, because that's the success of a bundled pricing system, is having all the providers with the same goal and achieving the same concept of quality of care. And now, Jean we'll discuss value-based healthcare.
Thank you, Whitney. So when we talk about value in terms of healthcare, we're really talking about the quality of a service and the cost of that service. So value should be measured based on health outcomes achieved per dollar spent to achieve those outcomes. So let's break down health outcomes a little bit. Okay, health outcomes do include health, satisfaction, safety, but for any medical condition, health outcomes should really be measured on multiple conditions. Okay, so we don't just want our patients recovering. All right, we want to know what's their ability to function. All right, what's their quality of life when they leave us? How satisfied were they? So the point is, achieving all of these health outcomes is really essential if we plan on ever achieving value-based healthcare. Now, moving on to the second part of the value equation, which is cost. Cost in this framework includes all resources used during the patient's full cycle of care. So this is clinical and administrative personnel, this is resources used, supplies, equipment, space, and so on. So bringing these two ideas together, cost and health outcomes, by standardizing a system to better measure health outcomes, and by using TDABC, as Luke spoke to you about, in order to figure out exactly what it costs to deliver these health outcomes, we're increasing the value of care the patient receives. Okay, but really, to achieve any of this, we really are going to have to look at value from the patient's perspective. And this really requires us to ask the question, how does whatever I do, whatever decision I make, help this patient? So value should be measured at the patient level. Specifically, when we when we measure value at the patient's level, we're talking about the quality of care the patient receives, as well as the satisfaction that they perceive. So as Porter would suggest, and we agree, using an IPU or an integrated practice unit can accomplish this. An IPU essentially integrates the patient into the healthcare process, and it structures the services around the patient and his or her needs rather than the department's needs. Okay, so now we know what value is. We know how important it is to integrate the patient into the process. So now the real question is, how does your hospital demonstrate value? How do you show patients that you value them? Boston Children's Hospital developed a standardized clinical assessment and management plan, which I'll refer to as a SCAMP. And a SCAMP essentially guides a physician in the treatment and assessment process, but it also allows for flexibility and modifications over time. So you can imagine just how important this is in a pediatric setting, because care is inherently costly. Children often can't describe to you just how they're feeling and what's wrong with them. So there's a lot of testing that's needed to establish a diagnosis. So yes, on one hand, clinicians need to be quite flexible, but on the other hand, they need evidence-based standards to reduce inefficiencies, reduce cost, and most importantly, improve care. Now, that should be pretty obvious. That should be the goal of any healthcare facility. But the reality is physicians need incentives to comply with this. This is what Elizabeth's going to discuss through physician bonus payments.
So there is a need to refine the goals of physician bonus payments. A new system would create the incentives for a new system would create the need for new incentives, and because in the past it's been production-based. But with a new system, the value-based model, it will be based off of quality, utilization, length of stay, and efficiency rates. And with utilization, we're looking at the measure of time. So the value-based model also rewards the physicians who put the patient first. And this emphasizes what Jean spoke to earlier about looking at the patient and the importance of the patient, of the care and the quality, putting that first. Utilization of the TDABC measurements will determine if physicians are making the necessary adjustments to patient care by reducing the inefficiencies, as Luke discussed, and by increasing patient care, by increasing health outcomes, and reducing costs. Our bonus calculation is based on utilization and length of stay. All but one of these cases is used primarily in the outpatient center, so the length of stay will technically be 0. We can also analyze based on scheduling time and if there is any variance when the patient leaves. So I'd like to thank you all for being here today. This has been a wonderful experience, and we are honored to present in front of you all. Thank you.
Well, great job. Great job. Really enjoyed it. You really covered the continuum very well. addressing the problem. I have a question for you. I've been in healthcare many years, and we come up against things like this, cost and issue and that. So TDABC, I sit here and I think, you know what, is this academia or is this reality? All right, TDABC, it will take a lot of cost to implement something like that. People to map out, people to set up the cost accounting system, people to generate it, people to work with the physicians. Then on the other continuum, you have the physicians who you're really going to have a battle with them because bottom line is you're cutting your reimbursement to them. So I say, is this something that academically looks good, or do you think that this could really, we could really use this methodology? It could happen.
Yeah, actually, that was my first question when I looked at the case study. I wanted to do more research to understand TDABC, to make sure it wasn't just a theory that's been applied in a few trials, but if it's actually had tremendous success. Now, TDABC expands upon the original activity-based costing methodology, which is true to TDABC may have higher costs and may be more difficult for hospitals to actually implement. Well, it's actually the opposite. It's easier to implement compared to activity-based costing, which is why Michael Porter adjusted his model. So with TDABC, we will be able to identify the cost per patient, and it's going to require less funding in order to do that, and less time by administrators and practitioners assisting in the implementation. That's according to Porter. Yes, I'm sorry. So that's according to Porter. But I also did further research too, and it has been proven to work in other hospitals as well, and so that which has had tremendous success. And thank you. I lost my train of thought. So, yeah.
Okay, I'm going to ask you to get into role for a moment. You are consultants, right, to Boston Children's Hospital, or are you on the staff of Boston Children's Hospital? Consultants? Okay. That makes it even more dangerous. All right, so as you probably know, I'm a member of the board of Boston Children's Hospital, and we're all very concerned about this. We know we've got to develop new reimbursement methodologies, health reformers here. Notwithstanding, however, the orthopedic department, and they are quite powerful in the hospital, orthopedics are, you know that, and part of their focus is the medical equipment, medical supplies, medical devices. And I noticed in your presentation the variation in the different casts and so forth. Now, as consultants, none of you have MD after your name, right? You're not physicians. And so my question is, how are we, the board, supposed to respond to the physicians, in this case the orthopedic surgeons, in terms of the importance of the medical device component and how this affects the physician's choice of product? I don't want anybody, as the board member, I don't want anybody telling our physicians what devices they have to use to provide quality care for the patient, because ultimately, as a board member, quality of care is my responsibility. I'm going to be the one that's sued, not you. Okay?
I think that for quality of care, the standardization of the processes and the bundled payment structure, where it sort of leads into a bonus payment structure. And I think that money sort of motivates anyone, and with physicians having the opportunity to sort of participate in that gain sharing from the cost reduction of standardizing their process and sharing best practices through stamps and maybe through the RFID, because it's very hard for, I think, the operational financial side and the physicians to sort of communicate. And I think with transparency on determining, standardized care, the cost potential savings, and allowing people to share in those savings as bonuses, it will, provide incentives and motivation and more knowledge and transparency.
Well done on your presentation. Dr. Mira Waters and Shaw, in a meeting, expressed concern about the issue of the cost of no-shows, scheduling, and communication. How would you address that issue?
Well, first with the no-shows, we need to determine a set charge for when people don't show. We need to charge them for that no-show. There's established benchmarks out there that you can use to determine that charge. And second, we also need to make sure that we are reminding our patients that they do have appointments, they do have procedures. Whether that's using the new, using different variations of social media, or sending emails, texting them, phone calls the day before, 2 days before, the week before. For example, MDMA has a breakdown of those costs, and it's much more cost efficient to follow that method rather than just not do anything and continue to have no-shows. You can decrease your no-show rate by 30%, decrease your cost by 30%.